Picture this. A man is 71 years old, retired, sharp as ever, still mowing his own lawn, still driving himself to Tuesday poker games. His wife finally convinces him to come in for a physical examination that he has been postponing for 2 years. Dr. Mandel looks him over and says, "Everything seems fine." Then he adds 6 words that change everything. "Let's just run a few tests." 3 months later, that same man is recovering from a procedure he never needed for a condition that would never have affected him. He is dealing with complications that have nothing to do with the reason he originally walked into the office. And the version of his life he had before that appointment, the lawn, the poker games, the independence, that version is gone. That story is not rare. That story has a name in the medical literature, and today we are going to talk about it honestly. My name is Dr. Mandel. I am a physician specializing in cardiovascular health and aging. What I focus on specifically is how the body's circulatory system changes after the age of 60 and what that means for how we make medical decisions. In my work with adults over 60, the pattern I keep seeing is this. People who felt perfectly fine going into a routine appointment and came out the other side dealing with something they never had before the testing process began. That pattern has a mechanism. It has a name. And once you understand it, you will never sit in a doctor's office the same way again. Here is the number that should stop you in your tracks. Studies estimate that between 15 and 25% of all medical procedures performed in the United States every year are unnecessary. But here is the part nobody talks about. That percentage rises sharply after the age of 65. Not because older patients are sicker, but because the risk-to-benefit equation changes completely after 65. And the medical system was not designed to calculate that equation during a 15-minute appointment. There is something called the cascade effect. It works like this. One routine test finds a small abnormality. That abnormality triggers a follow-up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And a person who walked in feeling completely fine is now managing a medical situation they did not have before they agreed to that first test. The cascade does not begin with the surgery. It begins with the first test. And that is exactly what today is about. I am going to walk you through 5 specific medical checkups that I would personally reconsider after the age of 65. Not because medicine is broken, but because after 65, the risk-to-benefit equation changes. And very few doctors are discussing that equation openly with you. I will show you why it changes, what I have seen happen to real patients, and I will give you a set of specific questions at the end of this video that can completely change the conversation during your next appointment. Stay with me through all 5. Number 3 is the one that surprises people the most because it involves a test that sounds like pure common sense. And number 1, the final one, is the checkup that almost nobody is questioning, even though the data behind it is more troubling than almost anything else on this list. Before we begin, leave your city or state in the comments right now. I read every one of them, and I genuinely want to know who is watching this video. It means a great deal to me to see the community that has grown around this channel. But first, there is one concept you need to understand, because without it, nothing else I say today will fully resonate. I call it the longevity lens. Here is how it works. When you are 50 years old, routine screening is often one of the best investments you can make in your health. You identify a problem early, treat it, and potentially gain 30 more healthy years. The equation is straightforward. The investment pays off. After the age of 65, 3 things fundamentally change that equation. First, many of the conditions that routine screening identifies in adults over 65 will never actually cause harm. They grow slowly, they produce no symptoms, and in a significant number of cases, you will outlive them. But once a result appears on a medical report, medicine does not have a leave it alone button. It has a treatment button, and that button often gets pressed. Second, your body's tolerance for medical intervention is not what it was at 50. A surgery that a 58-year-old recovers from in 2 weeks can mean months of recovery for a 73-year-old, along with complications, loss of independence, and a quality of life that may look very different afterward. Third, there is the cascade effect. One test, one abnormality, one chain of events that began from a place of feeling perfectly fine. Keep the longevity lens in mind as we go through every item on this list. All right, let's get into it. Starting with number 5. Checkup number 5. Routine PSA. Prostate testing after the age of 70 in low-risk men with no symptoms. This one requires precision because it is easy to misunderstand. I am not saying that prostate cancer is not real. I am not saying that PSA testing has no value. I am saying that for men over 70 who have no symptoms, no family history, and no prior concerns, the data on routine PSA testing tells a story that most men sitting in Dr. Mandel's office have never been told. Here is the core issue. A PSA test can detect a prostate cancer that is, biologically speaking, barely moving. A slow-growing tumor that, if left alone, would never spread, never cause symptoms, and in a 71-year-old man would almost certainly never shorten his life. He would live with it, not die from it. But the moment that result comes back elevated, medicine does not wait. Biopsies are ordered, specialists are consulted, treatment options are presented, and for a man who is 71 and otherwise healthy, treatment for low-grade prostate cancer can mean radiation, hormone therapy, or surgery, each carrying real risks to continence, sexual function, energy levels, and overall quality of life. The American Cancer Society updated its guidance specifically because of this issue. For men with less than a 10-year life expectancy, or for older men at average risk who have no symptoms, the risks of finding and treating a slow-growing cancer frequently outweigh the potential benefits. I want to tell you about Raymond. Raymond is 74 years old, a retired electrician from Tulsa, Oklahoma. He was fit, active, had no family history of prostate cancer, and absolutely no urinary symptoms. His routine PSA test came back slightly elevated during his annual physical examination. A biopsy confirmed a low-grade, slow-growing prostate cancer with a Gleason score of 6, which in medical terms means it is about as slow-moving as prostate cancer can be. His urologist recommended radiation therapy. Raymond trusted the recommendation and proceeded with treatment. Within 8 months, he was dealing with chronic fatigue that disrupted his mornings, urinary urgency that changed how he lived each day, and a quality of life that had declined in ways he never anticipated. When he sat down with Dr. Mandel 1 year after treatment, the words he used were, "I felt better before they found it than I do now that they fixed it." That sentence is not rare. It appears throughout the medical literature with a consistency that should give every man over 70 pause before automatically agreeing to a routine PSA test. So what should you do instead? If you have urinary symptoms, hesitation, changes in urinary flow, increased frequency at night, talk to your doctor. Those symptoms matter. If you have a strong family history of prostate cancer, that changes the equation. But if you are over 70, have no symptoms, and are considered average risk, the conversation with your doctor should not be, "Should we screen?" The conversation should be, "What would we actually do if we found something?" And, "Would that treatment improve my life more than carefully monitoring the condition?" That question alone often changes everything. Now let's move to checkup number 4. Checkup number 4. Routine bone density DEXA screening followed by automatic long-term medication. Before anyone misunderstands this section, osteoporosis is real. Falls can be devastating for older adults. I want to be precise here because there is a difference between questioning a test and questioning the automatic treatment pathway that often follows the test. A DEXA scan measures bone density. If the results show low bone density, many physicians immediately prescribe a class of medications known as bisphosphonates, including Fosamax, Boniva, and Actonel. You have probably heard these names in advertisements. The message is simple. Low bone density equals medication. Medication equals protection. But here is what that message often leaves out. Long-term bisphosphonate use, particularly beyond 5 years, has been associated with a rare but serious condition known as atypical femoral fractures. These are stress fractures of the thigh bone, the very bone the treatment is intended to protect. These fractures can be severe, often require surgery, and in some cases create more disability than the fracture they were originally prescribed to prevent. There is also a condition called osteonecrosis of the jaw. This involves deterioration of jawbone tissue that can be painful, difficult to heal, and in some cases triggered by the very medication intended to strengthen the skeletal system. Meanwhile, and this is the part that should be included in every discussion about bone health, the single most effective intervention for reducing fractures in adults over 65 is not necessarily medication. It is fall prevention, balance training. Research on Tai Chi in particular has shown that it can reduce fall risk by nearly 50%. Removing tripping hazards from the home, installing grab bars in bathrooms, reviewing medications that may cause dizziness, having vision checked every year. These interventions often reduce actual fracture risk more effectively than many medications, and they do so without medication-related side effects. Let me tell you about Gloria. Gloria is 72 years old, a retired elementary school teacher from Phoenix, Arizona. After her annual physical examination, she underwent a DEXA scan and was told that her bone density was below normal for her age. Her physician prescribed a bisphosphonate the very same day and advised her to continue taking it indefinitely. Gloria came to see Dr. Mandel 3 years later after developing persistent aching in her thigh. Further evaluation revealed an early atypical stress fracture. She had never experienced a fall. She had no history of fractures. She was taking medication intended to prevent fractures, and her bone was reacting adversely to that very treatment. So what should you ask before automatically starting medication? Ask, what is my actual fracture risk based on my complete health profile, not just this scan result? And, can we compare the potential benefits of medication with the benefits of a structured fall prevention program? That question is neither difficult nor confrontational. Any good physician should welcome it. Now let us move to checkup number 3. Checkup number 3. Routine cardiac stress testing in people without symptoms. This is the one that surprises many people because it sounds incredibly responsible. Your doctor says, "You are 68 years old. Let's just make sure your heart is doing okay." You get on a treadmill, or they administer a medication that temporarily stresses your heart while they monitor how it responds. What could possibly be wrong with that? Here is the problem that almost no one discusses in the examination room. Cardiac stress tests performed on people without symptoms, no chest pain, no shortness of breath, no dizziness during exertion, can have false positive rates approaching 40% in certain populations. That means that in nearly half of those cases, the test identifies an abnormality even though the heart is actually functioning normally. But medicine cannot simply ignore an abnormal result. That false alarm often pushes you into the next stage of the cascade, cardiac catheterization. A thin tube is threaded through your blood vessels, usually through the wrist or groin, and guided directly into the heart. The risks include bleeding, blood vessel damage, heart rhythm disturbances, and in rare cases, the catheterization itself can trigger the very cardiac event the screening was intended to prevent. And if the catheterization discovers a partial blockage, which is extremely common among adults over 65, including many who may live for decades without a single cardiac event, you may be advised to receive a stent. Now, this is the part I really want you to hear. Multiple major clinical trials, including the ischemia trial, one of the largest studies of its kind, found that placing stents in patients with stable coronary artery disease did not reduce heart attacks or extend life when compared with medication and lifestyle management alone. The stent did not outperform a 30-minute daily walk combined with appropriate medical therapy. However, it carried all of the procedural risks and often required years of blood-thinning medication afterward. So the cascade often looks like this: feeling fine, routine stress test, false positive result, cardiac catheterization, stent placement, blood thinners, ongoing monitoring, no statistically significant improvement in long-term outcomes. That is the complete picture, and it all began because someone said, "Let's just check." If you are finding this information valuable, type the number 3 in the comments. It is a simple way to let me know you are following along, and it genuinely helps this channel reach more people who may benefit from this information. So what should you do instead? If you have no chest pain, no unexplained shortness of breath, and no dizziness during physical activity, the conversation with your doctor should not primarily focus on stress testing. It should focus on optimizing the factors that actually drive cardiovascular risk: blood pressure, cholesterol, blood sugar, physical activity, sleep quality. That is where the greatest cardiovascular gains occur after the age of 65. And none of them require a catheterization to achieve. Now let's move to checkup number 2. Checkup number 2. Routine carotid artery ultrasound in asymptomatic patients. Almost nobody is talking about this one, and based on what the evidence shows, that silence may be one of the most significant oversights in routine senior healthcare today. A carotid artery ultrasound examines the large blood vessels in the neck that carry blood to the brain. The concept sounds logical. Identify a blockage before it causes a stroke. Surgically remove the blockage. Problem solved. But the reality is considerably more complicated, and for people without symptoms, potentially more dangerous than it sounds. Here is the fact that changes everything. The surgical procedure commonly used to treat carotid artery narrowing, known as a carotid endarterectomy, carries approximately a 2 to 3% risk of causing a stroke during or immediately after the procedure. In older adults with additional health conditions, that risk may be even higher. The United States Preventive Services Task Force, the organization widely regarded as the gold standard for screening recommendations in the United States, specifically advises against routine carotid artery ultrasound screening in adults who have no symptoms. Their conclusion is straightforward. For asymptomatic individuals, the risks associated with intervention generally outweigh the potential benefits. Here is why. A substantial proportion of adults over 65 have some degree of carotid artery narrowing. In many cases, that narrowing has existed for years. It remains stable, it remains silent, and it never causes problems. But when routine screening detects it, a well-intentioned specialist may recommend fixing it. The problem is that surgery performed on a blockage that was never causing symptoms can dislodge a small fragment of plaque. That fragment may travel directly to the brain. The intervention ends up causing the very outcome it was intended to prevent. So what should you do instead? If you have no neurological symptoms, no sudden vision changes, no facial drooping, no arm weakness, no brief episodes of confusion, and no episodes of slurred speech, routine carotid artery screening is generally not recommended and should not be your primary focus. Your attention should be directed toward managing the factors that genuinely increase stroke risk: blood pressure, the most important one, blood sugar control, atrial fibrillation, if it applies to you, and maintaining consistent physical activity. However, if you experience any of the symptoms I just mentioned, even briefly, even if they disappear completely, that changes the situation entirely. Seek medical evaluation immediately. At that point, we are no longer discussing routine screening. We are talking about your body sending a warning signal that deserves urgent attention. Now we arrive at checkup number 1. Checkup number 1. Routine colonoscopy after the age of 75 in low-risk asymptomatic adults. This is the one. The one that most people have never heard challenged, because colonoscopies have been so thoroughly endorsed for so many years that questioning them in the appropriate context can feel almost counterintuitive. But the data for adults over 75, specifically those with no symptoms, previous clean colonoscopies, and no family history of colon cancer, tells a different story than most people have heard. The United States Preventive Services Task Force explicitly recommends against routine colonoscopy screening in average-risk adults over the age of 75. Their reasoning is not vague. The risks begin to outweigh the benefits. And those risks become very real when you understand what can go wrong. A bowel perforation, a literal tear in the wall of the colon, occurs in approximately 1 out of every 500 colonoscopies. For a younger adult, that may be a manageable surgical complication. For a 77-year-old, it can mean emergency surgery, a colostomy, prolonged hospitalization, and a recovery process that permanently changes independence and quality of life. And that is not even including the preparation itself. The bowel cleansing solution required before the procedure can cause dangerous dehydration, electrolyte imbalances, and significant cardiovascular stress in older adults. There is also the risk associated with sedation, which increases with age. And then we return once again to the longevity lens. The colon cancers most likely to be discovered in asymptomatic adults over 75 tend to grow slowly. Slowly enough that, in many cases, they would never cause meaningful problems during that individual's remaining lifetime. I want to tell you about Margaret. Margaret is 78 years old, a retired schoolteacher from rural Ohio. She had undergone 2 colonoscopies during her 50s and 60s, both completely normal. No polyps. No family history. No symptoms of any kind. Her new primary care physician reviewed her chart and told her she was due for another screening. Margaret asked questions. She was reassured that it was routine, so she agreed. The preparation affected her severely. By the following morning, she was confused, weak, and barely able to stand. Her daughter brought her to the emergency department before she ever reached the procedure. Her electrolyte levels were critically low, and her heart was under significant strain from dehydration. She spent 5 days in the hospital. She never actually underwent the colonoscopy, and the findings from those 5 days revealed that her heart and kidneys had been stressed by a process intended to screen for something she almost certainly did not have, and even if she had, would most likely have outlived. When Margaret called Dr. Mandel after being discharged, she said, "I felt better when I was overdue for that test than I did after trying to take it." So what should you do instead? Ask your doctor about non-invasive, stool-based screening options such as Cologuard or an annual FIT test. These tests can identify meaningful warning signs without exposing you to the procedural risks associated with colonoscopy. And if you do have symptoms, blood in the stool, unexplained changes in bowel habits, persistent abdominal pain, or unexplained weight loss, that changes the equation completely. Those symptoms deserve medical evaluation regardless of age. Now let us move to the practical advice I promised earlier. Every time a doctor recommends a screening test, especially if you are over 65 and feeling well, I want you to have 5 questions ready. Write them down, save them in your phone, bring them to every appointment. Question number 1. What is the false positive rate of this test in people my age? This question tells you how likely the test is to send you into a series of follow-up procedures, even when nothing is actually wrong. Question number 2. If this test finds something, what are the realistic treatment options for someone my age and health status? Do not let the discussion stop at, "we found something." Push the conversation one step further. And then what? Question number 3. What is the procedural risk of the treatment we would most likely pursue? Every procedure carries risk. You deserve to understand that risk before the procedure, not after it. Question number 4. What happens if we monitor this instead of treating it immediately? For many conditions identified in older adults, watchful waiting is a legitimate and often superior approach. That is not giving up. That is making decisions based on appropriate risk-benefit analysis. Question number 5. What is the most effective non-invasive approach for this condition? Because as you have seen today, whether we are discussing bone health, heart health, or stroke prevention, lifestyle changes and appropriate medical management frequently outperform invasive procedures while curing only a fraction of the risk. Any physician who genuinely has your best interests at heart will welcome these questions. They will not make you feel difficult for asking them. And if a doctor dismisses those questions or makes you feel like a problem patient simply because you ask them, that is important information about whether that physician is the right fit for you. Here is what I want you to do starting today. Before your next appointment, whether it is next week or 3 months from now, write those 5 questions on a note card or save them in the notes application on your phone. Do it today. Bring that card with you. You may not need all 5 questions. You may only use one. But having them available changes how you enter that room. And how you enter that room can change the decisions made about your health. Try this for the next 30 days. 1 appointment, those 5 questions, and I can tell you what you will notice. By the end of those 30 days, you will feel like a different kind of patient. Not a difficult patient, a protected patient. Someone who understands why tests are being ordered, what the follow-up procedures mean, and what questions should be asked before the cascade begins. There is probably someone in your life, a spouse, a sibling, an adult child, or someone helping care for aging parents, who needs to hear what we discussed today before their next annual physical examination. You do not have to explain it all yourself. You can simply send them this video. If this conversation has changed the way you think about routine medical care after the age of 65, subscribe to this channel. Next week, Dr. Mandel will be discussing something that connects directly to everything we talked about today. Specific medications that are routinely prescribed to adults over 65, but carry a completely different risk profile at that age than they do at 50, and the questions you should ask your pharmacist before refilling them. If you take more than 2 daily medications, that video was made for you. Leave a comment below. Have you ever had a routine medical test lead somewhere you never expected? Your experience in the comments section may be exactly what someone else needs to read before walking into their next appointment. Take care of yourselves. I'm Dr. Mandel, and I'll see you next week.